You're here today because you signed up for this session about survivorship in 2026. We're going to talk about what's on an oncologist wish list and how to get it started. And I have with me today Dr. Aulakh and Dr. Bailey-Dorton, who are going to share their experiences from a clinical point of view. And I would just want to give you a bit of a background of why the Africans organizes these sessions. We are a digital platform for cancer survivorship, and we love raising awareness on the importance of survivorship. Really share resources with all of you who are on the ground working with patients every day of how you can support them and what are the main topics. Um, to share a little bit more on our backgrounds, we really believe that treating cancer is just the beginning. And so that's why we have created this platform that is fully online, that makes creating comprehensive survivorship programs possible in a cost-effective way. And so the solution is cost-effective, it meets COC requirements, and it also provides detailed reporting and insights. We've also shared and shown that survivorship brings really positive patient outcomes. And the way that we do this is with this new approach, which is an app where patients get a daily plan, they get educational libraries, they get group sessions, community where they can share and meet other folks, but also have access to 24/7 supports on our chatbot. Start by asking you to introduce yourself. Well, Dr. Chasse Bailey-Dorton, I can see you are already unmuted, so you can start.
Sure, thank you. So happy to be here today. I come at this area of survivorship both as a cancer survivor and as someone who practices integrative medicine, integrative oncology in a large cancer center. So I'm thrilled to be here. Looking forward to our conversation.
Hello, everyone. Thank you for joining us. I'm a translational neuro-oncologist, and um, what survivorship is sort of what I totally believe in before, during, and after. And we always are striving to include that in our clinic, in our research, or a combination of both of those in our trials. So I'm thrilled that we will be discussing about it for an hour, because I typically don't get to discuss survivorship for an hour with all of you wonderful people who have joined online.
We're excited to have you here and to have a full hour to talk about such an important topic. And this session is also being recorded, and we'll share the recording with you so you can have a look at it afterwards, but also share it with your colleagues. So I think there's two things I want to get started with today. I want to understand what drove your interest in survivorship and how do you define survivorship? Dr. Bailey-Dorton, you go ahead.
Sure. Like I said, mentioned, I am a breast cancer survivor. And while I wasn't shocked by the treatment I got, I was kind of surprised about what didn't happen at the end of my treatment. There wasn't really follow up. There was not any education about long-term risks. There was no education about how do I decrease the risk of recurrence. And it was kind of like getting dropped off a cliff where I'd been in this close environment of seeing an oncologist every week, having a nurse navigator, having clinic nurses, infusion nurses, all these people surrounding me to, we'll see you back in about 3 months. And that kind of led me to trying to figure out, hey, something needs to be done. Not only was I looking for answers for myself, but to help other patients. So that was what kind of drove me into this.
And how do you define survivorship?
Well, for me, there's two really models out there. The one is to being defined at the time of diagnosis. The second one that's most commonly used is that we define survivorship at the end of treatment. But there's two problems with that. Defining it at the end of treatment leaves out a lot of folks who are now metastatic or stage 4 and don't really fit into that model, and they have a lot of long-term survivorship needs. And when you define it at the end of treatment, you're missing that whole window of working with the patient at the time of diagnosis to help them through that treatment. So the current definition doesn't really include it all. I agree that we need to start at the time of diagnosis.
Thank you for that. Dr. Olak, could you share what drove your interest into the survivorship and how do you define cancer survivorship?
Thank you, Dr. Bailey-Dorton, for kickstarting this. I think of survivorship as it's not just about beating cancer, it's a lifelong journey that starts the moment of diagnosis and continues through every phase of life thereafter. If you look at the data from NCI and NCCN, anyone diagnosed with cancer is a survivor from day one, encompassing acute treatment, extended remission, and even permanent survivorship for those living with chronic or metastatic disease. But let me paint a picture. Imagine a patient like one I have treated, a young woman from rural West Virginia diagnosed with glioblastoma, which is one of the most aggressive brain cancers. Her survivorship isn't merely surviving the cancer, it's navigating cognitive fog from radiation, rebuilding her emotional resilience after chemotherapy, and integrating back into her community despite transportation hurdles and financial hurdles. In neuro-oncology, where brain tumors can alter personality, memory, and independence, survivorship means holistic support, medical surveillance, yes, but also addressing the invisible scars like anxiety or sleep disruptions that lingered long after scans show no evidence of disease. Similarly, data from American Cancer Society's 2026 report shows over 20 million survivors in the US, with brain tumor survivors facing unique challenges, and up to 50% report persistent cognitive issues years later. So it's about thriving and not just enduring. And that truly drives me to focus more on survivorship, but also include survivorship definition in our daily clinic life.
I think that's a good definition too. I can remember having a young brain tumor survivor in one of my clinics who was just stuck. She had feared planning for the future. She was engaged, but she feared going through with that engagement because she was so uncertain of her future. And you're right, that's a huge area that we need to put more resources towards.
Yeah. And that's something that you definitely see across all cancer types, right? That fear that sometimes like block us from planning the future. Dr. Olak, you mentioned holistic support complements the medical treatment. Could you maybe share more detail on like what are the topics of that support should encompass?
So essentially what we're talking about, what should an integrated survivorship program look like in 2026? And I'll add a flavor of rural focus. So picture a seamless ecosystem where survivorship isn't an afterthought, but a core pillar from diagnosis. So I'd envision a risk stratified model. Low risk patients transition to primary care with digital monitoring, while high risk ones, like glioblastoma survivors, or for that matter, any metastatic cancer survivors, get multi-D teams, including oncologists, psychologists, and rehab specialists. We did a study which was funded by Pfizer on patient-reported outcomes, and we had used apps for real-time symptom tracking. Fatigue spikes alert the team instantly. In rural America, where research shows geographic barriers worsening, in my case, it's glioblastoma outcomes, but how telehealth can bridge the gap, how we reduce the travel for follow-ups. And the holistic elements are the key. You can embed exercise prescriptions, nutrition counseling, and even sleep therapy. Our feasibility study on clinic-embedded rehab therapists show improved mobility and quality of life in neuro-onc patients. And the other thing is you can imagine a VR for cognitive rehab or AI predicting relapse risks. But equity is crucial. So programs must address rural-urban divides, where American Cancer data reveals 5 to 10% lower survival in non-metro areas due to access gaps. My wish is that we should have these federally funded hubs in rural and subserved areas, blending precision medicine with community support. So you can see there are multiple elements to this holistic approach, and that's the perfect model with community engagement.
Yeah.
And I think it's true that no matter where a survivor is, they should have access to the same holistic survivorship program as somebody in the big city. When I meet with a patient, I tell them that my job is to load the boat with everything possible to help get them through treatment, recover, and decrease risk without sinking that boat. Meaning there's a lot of misinformation on the internet. There's always somebody trying to sell them something. Suddenly they have family members who read something in a newspaper or online and said, you need to do this and you need to do that. We got to make sure we're helping their care, not doing something that might interfere with that care, to make it that whole picture. Like you mentioned, nutrition, exercise, sleep, supplements, sexual health. Nobody talks about that for our patients. Decrease environmental risk, that whole package that we need to put together and load the boat for these folks, no matter where they live.
Yeah. And Dr. Bailey-Dorton, I know you have a fellowship in integrative medicine, and so you practice survivorship using that integrative medicine knowledge. Could you walk us through the different pillars of support that you provide patients and maybe how you run your practice?
Yeah, certainly. If I see somebody who's newly diagnosed, the things we go through that first visit is let's talk about nutrition, because that's something people are typically all suddenly fasting or juicing or something because they're seeking something that they can control to help themselves because they've just been into this scary hurricane. So nutrition is an aspect. We talk about physical activity. I talk about the benefits of being physically active through treatment. Can maintain that muscle mass. It's going to help fatigue. It's going to help to give them a chance at better outcomes. We talk about sleep. I haven't met a survivor yet that didn't have trouble sleeping. So what can we do to get them that restful sleep during treatment? We'll talk about supplements, what they should maybe take and what they shouldn't take, how we need to be very, very cautious with supplements during treatment, try to avoid as many potential interactions as possible. We'll talk about stress, just the stress of this diagnosis, the stress of treatment, the stress on their family. We'll talk about, how can you reduce environmental exposures? Because that's something I'm already working for at diagnosis towards their long-term survivorship. So I'll put together a plan during active treatment. And then after we get through treatment, we'll do a plan at the end of treatment saying, okay, what side effects do we need to address? How do we decrease your risk of recurrence going forward? What type of follow-up do you need?
Thank you. Dr. Aulakh, I don't know if you want to share how you've seen this work in your practice and in your clinic.
I would certainly echo Dr. Bailey-Dorton's integration of different approaches. And what I would add to that is that I've realized in a practice the demands of these integrated approaches vary, not just for one patient, but also for different patients, but also for the same patient at different time points. So to have the ability to understand which one to prioritize at a single visit in a limited time we get as oncologists to while we are discussing their cancer, their treatments, their future plan, I think it is so important to even address one at a time and understand that over time we would be able to help address all the elements. Yes, there is palliative care clinic, there is quality of life deliverables or objectives. But at the same time, I think because we have built the most rapport with these patients for a long time, what we say to our patient becomes the voice. And then once you start establishing them with different specialists over time, they feel more comfortable. So I always do this stepwise approach to help them. And one of the biggest hurdles being in rural areas is transportation and also lack of um, s- special rehab centers across the state. So what we try to do is we bring them to a specialist here, who then connects them to different clinic in the state, and that helps them stay closer to home for their holistic treatments rather than us adding extra burden for them to come here and go back and forth. So I feel every patient is so unique, and just asking them a question about what do you need the most? Sometimes it's the childcare, sometimes it's I can't lift my husband from the chair anymore. He's too big for me. Where do you send? Is that the end where we send them to hospice? Probably not. Just need extra care. And how do you connect home health folks to help them more than an hour a day? So every um, scenario becomes a very unique learning experience in itself.
I think one of the questions I ask at the end of each visit is, how can I help you the most? Or what's the most important issue for you? And often it's not the one that I identified as the most important. It's something totally different that they have on their mind that we need to address first. What you mentioned is, access in rural areas to some of these integrative modalities. I'm now in a rural area and I'm still struggling to find an acupuncturist for my patients. So these disparities that we need to try to figure out how to deal with.
I think both of you mentioned like lifestyle as interventions. You mentioned nutrition, you mentioned physical activity. What is the best way that providers, and we have a lot of like nurses and social workers and clinicians in this call, how can they help their patients move from a theory of you need to eat well into like practice? What is the best way of coaching patients to get those tips, but then like actually put them into practice at home? Dr. Aulakh, you were nodding. I don't know if you have any tips.
No, I was gonna let Dr. Bailey-Dorton go first with her experience. I was nodding so she can go ahead.
Well, it's funny because I always say that food is such an emotional issue. And trying to get somebody to change what they eat is harder than it sounds sometimes. And I know certainly in some of the neuro patients, they're all trying to go. There was a few studies about keto, and all of a sudden, all these patients were eating keto, but you can't necessarily translate that to other cancer types. I think a lot of it is just starting where they are. What is their current nutrition status? What are Sometimes I ask them, what's the good, bad, and ugly about your diet? And many times they will come forth knowing the areas they need to improve on, and really making use of your cancer center nutritionists and dietitians too will help you. But it's a hard thing to do because it's such an emotional topic.
Yeah. Um, and to again, we talked about lifestyle, we talked about physical like side effects. What about the emotion and psychosocial challenges? Like what are the biggest hurdles that these patients are facing and how can we help them?
Well, I think it differs and it will transition through the treatment. Initially they've heard that word cancer, they've suddenly thrown into this scary hurricane, more doctors, more tests than they ever expected. They're scared. Whereas when you get to the end of treatment, I sometimes tell patients, hey, actually, the end of treatment's harder than the beginning sometimes. Their thoughts are, I didn't know I had this. Now I have these side effects. Is it going to come back? Will I know if it comes back? And can I do anything to keep from coming back? And most of these folks truly have almost a PTSD from what they've been through. And really trying to get in there and address that for them emotionally, I think is one of the most important things we can do.
I agree. And I often, being a neuro-oncologist, insomnia and emotions obviously are a big part of my practice, and I think they're deeply interconnected. But even in other cancer patients, there's sort of a bidirectional cycle: poor sleep worsening emotional distress, while negative emotions like worry or sadness, it disrupts sleep. Um, Evidence does show that sleep disturbances affect 50 to 95% of cancer patients. It's higher during active treatment like chemotherapy, with prevalence around 60% in multiple meta-analysis studies. So the strategic plan for sleep and emotions, one is screen routinely. There is a Pittsburgh Sleep Quality Index. Then there is NCCN distress thermometer plus problem checklist to identify contributors, pain, fatigue, medications, and then setting a goal. And fourth is implementation of those core interventions, which are multimodal approaches. Um, One would be cognitive behavioral therapy for insomnia. Luckily, in my practice, we have an on-site neuro-oncologist, neuropsychologist who helps me evaluate the core issues and is able to get patient to cognitive behavioral therapy. Second, mindfulness-based therapies, meaning-centered or positive psychology approaches, some brief interventions, relaxation, journaling emotions, or stress reduction, which I do that sometimes for myself, but some basic level of interventions, sleep hygiene integration, um, having them have a diary of sleep schedule, same bedtime, same waking up, limiting caffeine, alcohol, some sleep environmental education like cool, dark, quiet room, daytime activity, which does entail some exercise planning because sometimes patients are so tired from chemotherapy, they're sleeping on their chair and then they have hard time sleeping at night. So trying to reset that cycle, or at least making them aware. And I think the final phase of this sleep and emotional care is consistency um, in monitoring and adjusting based on what phase of treatment they are in and what phase of cancer journey they are in.
Yeah, I think the other thing too, just adding on to that, especially I know in the neuro-onc world, is the support that they have. Is this a spouse? If they're lucky enough to have somebody there with them, is it a family member? And those folks are often overlooked. Some literature will call them co-survivors, but I can't tell you how many times I've been in a room with a patient and turned to their spouse or their family member and say, "How are you doing with all this?" And many of them say, "This is the first time anybody's ever asked me how I'm doing getting through this." And they're the overlooked population we have to help address too.
Yeah. So we touched lifestyle, we touched side effects, we touched psychosocial needs. I would say the fourth large bucket of survivorship when we think about post-treatment is follow-up appointments and scans. What is your experience in driving better engagement of patients to go through the follow-up appointments and scans and improve their whole experience on the post-treatment phase? Dr. Bailey-Dorton?
Well, I think it has to be the value of that appointment. I've had some patients tell me, my survivors, this is the one appointment I look forward to because it's empowering. It's helping me feel like I'm stronger and making changes. So I think there has to be that value that we're giving them in that appointment is one of the biggest things. And then I think, there's always this confusion about who's following what. Are they referred back to the primary? Is there a survivorship clinic? Is there an oncologist? And having a clear path for that. In the past, there's been this, there still is these survivorship care plans that were, they kind of thought that was going to address this issue. But what I found is just kind of a summary, but nothing ever happens with it. It doesn't go anywhere. We've got to really get in there and look at what residual side effects they have, and really helping them deal with that fear of recurrence. I tell my patients that, look, cancer is this elephant in the room. It can be big when you just finish treatment. I'm 23 years out. The elephant's still in the room, but it's little. But there can be things that make that elephant grow, whether it's an upcoming scan, whether it's an upcoming appointment, whether it's a change in your body, a symptom. We have to help them learn how to deal with that fear of recurrence.
So I think that this is one of the key questions. When I began the survivorship discussions, especially after completion of treatments, I always start with congratulations, you have completed the hardest part. The treatments work to shrink or remove the cancer we could see and treat. Now we move on into a different phase, and I call it watchful partnership, where we schedule regular check-ins, and depending on your cancer type and stage, some imaging or blood tests. And at that point, the goal isn't to live in fear of what might come back. It's to stay ahead so that if anything does appear, we can catch it when it's small and more manageable. And I, based on what kind of treatments they had received before and how frequent I will need to follow them after their treatment, I put sort of a personalized survivorship care plan for them, printed, simple, 1 or 2 pages that outlines the schedule. Every 3 to 6 months for the first couple of years, then tapering. And I explain why we avoid overscanning in asymptomatic people. Then the engagement starts with trust and transparency. Patients often ask, do I really need all these appointments? Or what if I feel fine? Can we skip the scan? I validate the fatigue. And I try to say it's completely normal to feel done with medical settings after months of treatment. Many people face scanxiety, and that knot in the stomach waiting for the results. We can talk through ways to ease it, like breathing exercises before the appointment or getting results by phone if normal. One of the practical barriers in rural America is transportation. We try to connect them to ride programs or telehealth options for visits. Sometimes there is work conflict, so we flex timing or bundle blood work with imaging. Sometimes there are cost concerns, so I flag financial navigators early on, and then reminders that are non-negotiable. Our system sends auto texts and emails and some sort of messaging that they need to show up for these appointments. And so every appointment after the treatment ends becomes sort of a positive reinforcement. And I always end with, start with congratulations and end with that you have stayed on track. Great job. And that really reassures patients to continue to wanting to come back, because they know that we care about their scans, their blood tests, about them, but we also understand the hurdles.
I love that watchful partnership. I think that's a great term.
Yeah. Thank you for sharing that. So we talked about the topics of survivorship. I think both of you have shared a little bit of the how, but I would love to deep dive now on like how to set up an ideal survivorship program. If you were going to start from zero with everything that you know today, what would an ideal survivorship program look like? Dr. Chasse Bailey-Dorton, I know you've done this a few times and not too long ago. Do you want to share your experience with us?
Well, I'm going to be biased and say you need to have a really good integrative oncologist as part of your treatment team to start meeting with the patients up front. I think you need to have those validated, evidence-based complementary therapies available, whether that's, acupuncture, massage, healing touch, a strong exercise program. And I think you need to have the thing that comes toughest sometimes is that buy-in from the oncologist. They know what they're doing, but sometimes it's convincing them that this is a evidence-based program that wants to come along beside them, that I know they're doing survivorship care, but it can be so much more. There's always been that tough back and forth between an oncologist who has a great patient who survived, that they like to see those folks in cancer. They like to see their long-term survivors in clinic. And it's tough sometimes to say, well, now we're going to take them away from you and put them over here in your survivorship clinic. But I think the bottom line, my bias is we need to have a good integrative folks on that treatment team.
I 100% agree with you. And honestly, I think about it every single time I'm in the clinic, that how can we best help our patients beyond me? I'm 20 minutes of their life in a day, and all I have delivered is cancer, treatment, side effects, scans, labs, and I'm trying to help them understand the terminology while focusing on molecular classification, telling them off-label, having them sign the consent. But that's not it. And I always say that when they're in the clinic, that 20 minutes of our conversation will stay with them until we see each other again. So I think the core elements, what I think would make an ideal integrated survivorship care would be one, dedicated leadership and coordination. I think centers should have survivorship program coordinators, which actually is required by COC. Could be an oncology navigator, nurse, or an APP who can oversee the operation. Two, multidisciplinary team, which most of the tertiary or quaternary referral centers do have, which has an oncologist, nurses, social worker, neuropsychologist, registered dietitians, PT, OT, palliative and supportive care clinic. And I think third, which we often miss, is personalized survivorship care plan, where you have a treatment summary and a follow-up roadmap. I've seen that in ASCO and NCCN templates, which does mention this is your diagnosis, because each patient has different cancer diagnosis, different treatment plans. So based on that, the late effects are different in each cancer subtype and based on what treatments they received. Then surveillance schedule, wellness recommendation like exercise, nutrition. And finally, I think the key service domains, we should offer at least 3+ on an annual basis. Surveillance for recurrence, new primaries, late long-term effects management, psychosocial support, lifestyle and wellness promotion, either via coaches or some online or some printed material, because this will help us evaluate the needs and also provide equitable care, which is customized to each patient based on what they had in the beginning.
And of course, the big gap for a lot of this is reimbursement. So most of the integrative programs that I've been associated with were started with philanthropy funds. As you grow them and show the value to the system. But that's where a lot of this has to start, and finding more cost-effective ways to provide a lot of these services. I always say the good thing that came out of COVID is we now have telemedicine. We did not have that before, and it's allowed us to really expand that to bring more services available like the after cancer to folks.
Yeah, go ahead, sorry.
No, you go ahead. I was gonna just mention that I know lots of um, pharmaceutical industry is also focusing on PROs, which I think is an excellent approach because that helps us do some feasibility or pilot study, and that can transform into bigger, major, even if not clinical trial, because I think everybody understands what a survivorship looks like, how it should look like. At least majority of the people who have ever taken care of a cancer patient, they understand. But how to have specific models, for example, um, tech-enabled and shared care, then disease-specific tracks, hybrid APP-led model, a quick start, low resource, community practice or small center. I think we understand, but even if we get some funding, if it's not covered by specific codes that we use for survivorship, that can lead to a major impact. And that's why we're discussing these critical issues through you, Mariana, and Dr. Bailey-Dorton, and everybody who has joined. And I think that's the top-notch level of care we can provide to our patients who have cancer.
I love what you just mentioned, because that's where I was going to take the conversation into, is what are new approaches or new modules that we can use and that clinicians can use to expand care and expand access to survivorship care. I am extremely biased because we built the After Cancer as a digital platform because we knew of the transportation issues and like access in rural areas and how hard it is to get um, like the right expertise in terms of like hiring integrative oncologists or even like nutritionists or psycho-oncologists. And so we really believe that by creating a program that is fully online, that patients can have on their phones 24/7, would not only help solve access, but also helps solve engagement. Because something that I've experienced as a caregiver is the hardest thing was to put theory into practice. Like the hardest thing was our doctors telling us that we need to exercise more and eat this or eat better and sleep better. But like, how do I go home and have this piece of paper with recommendations and put that into practice? Like that's hard. That's behavioral change. Like we're humans. We're not used to that, especially by ourselves. So, Dr. Bailey-Dorton, I know you're extremely biased here too with your physical program and like the role that you're playing with the after cancer, but if you could just share your experience in using digital platforms to support your patients.
Well, the other thing too is many of our patients, once they finish treatment, are now back working full time. So they've already taken this time away from work to get treatment, and now they're trying to balance the time of getting more time away to do these programs. And I'll have to use the example. Kenny, I hope you don't mind if I use you as an example, but I had a patient that I treated one time through lymphoma diagnosis, and the whole visit was virtual. And we had this event one time, and it was a donor event, and we got together and we realized the first time we'd ever met each other in person. We had established this relationship virtually. And if you had asked me before that, I said, no, you can't. When virtual visits first came out, I said, no, man, I'm integrative. I got to see the person. I got to hug the patient. We got to talk. I got to have, see what they look like, see how they react. I'm not sure this is going to work. And that experience taught me is that you can establish that deep relationship with a patient virtually. if it's done the right way. And I think that's what we've learned is so many of these programs we can provide virtually to the comfort of your own home. Sometimes going back in that cancer center is a trigger for a lot of our patients. Providing these services back in their home, providing them at lunchtime when they're at work, providing them in the evenings in their home, that we really can go in and do that. So I think that's the step and that's the benefit that we've gotten out of this. And we have to expand in that direction. Now, I haven't figured out how to do the acupuncture virtually, but if we get to that, I'll let you know.
Thank you.
Mariana, you've asked such a great question that what are the modern ways of, integrating survivorship with the cancer care? Because I always think, the anchoring is that it's an afterthought, but it's not. So I think the hybrid collaborative models, which could be very scalable, can work where we can embed an oncologist survivorship slots or have an APP-led survivorship slots directly into an oncology clinic workflow. Use risk stratified pathways, high risk versus moderate risk versus low risk. And what that does is it frees time for more complex cases. The second is oncology primary care integrated clinic. I have a very good colleague here, and she works in a transition care clinic. What that means is if patients have been discharged from the hospital, but let's say they have a biopsy of a concerned site, but we don't have the diagnosis. So those patients go to her clinic, and from there, depending upon if it's not cancer, she manages them. If it is cancer, whether it is primary or secondary, it comes back to us, and it improves continuity, comorbidity management, and long-term adherence. Third, as Dr. Bailey-Dorton, you guys were talking about virtual and telehealth enabled survivorship. I think that's an excellent opportunity and the right usage for telehealth medicine. Obviously, I know there are changes in insurance where in some states telehealth may not be as widely used as we were using a couple of years ago, but it still reduces travel burden, improves equity access, and also fits value-based models. Fourth, which I think is one of my favorite, is forward-looking accelerator, where you can have technology and AI enhanced integration. We can embed some AI tools in EHR for flagging late effects, use multiomics AI for dynamic survivorship, where you can even track your own biomarkers longitudinally to adapt care. And then digital platforms, which we have used here for patient-reported outcomes collection. A little bit of learning curve there, but it's doable. And finally, I think this whole person interdisciplinary embedding, which is a holistic default, is quintessential. Having this multidisciplinary one-stop clinic. There's a RISE model, blending rehab plus lifestyle medicine, because it is difficult to study each aspect of the survivorship by one person, because there are diet modifications, there are other medications that these patients are on, and how do we help them understand the significance of maybe a special kind of diet that would not interfere with these other medications. And then dividing into short-term and long-term plans. I think these are very practical, doable, modern approaches that are possible with the help of community and hospitals and also bigger industries.
Thank you. We're getting a lot of questions on the chat, so I think it's almost time to move to a Q&A. I just want to close with the last question. The title of the session was What's on Your Wish List? So I now need you to answer what's on your wish list. So top three things. Top three, let's do it words to make it catchy. On your wish list, Dr. Bailey-Dorton.
Exercise involved for every patient. The quote I love, I don't know who to credit to, is we don't lose muscle because we age because we lose muscle. So exercise, the nutrition, and dealing with the cognitive behavior fear of recurrence.
I think my top wish is working on fatigue, which goes back to Dr. Bailey-Dorton's point of involving patients and survivors with exercise-based regimens. Second, I would say prescribing exercise and sleep as standard with very specific instructions. And third would be fusing precision therapies with holistic support, where they transform survival into vibrant living. And that's where the community support becomes quintessential.
Thank you. So let's open to the Q&A. I saw there's a few questions on the chat. I don't know if you want to just raise your hand and unmute yourself so we can have a conversation. Otherwise, I'm happy to read from the chat. Claire.
Hi, my name is Claire Rumor, and I'm really happy to be here. I'm here as a stage 4 cancer survivor, but also as a 15-year intimacy coach and sex educator, and the creator of a new website called cancerandintimacy.com. So my question is very themed, and it is, what are your opinions about why intimacy, relationship support, and things like body image aren't included as standard of care in survivorship yet?
I always think some of it has to do with the provider's comfort level of discussing those issues. Often I'm the first person who says, tell me about sexual functioning, tell me about sexual health. And their patients are like, we've wanted somebody to ask them that, but nobody's asked them that before. And I think you're right. We have to look at the body image, especially if it's a GYN or a breast cancer that a sex organ's been removed or treated. And then I think also helping that relationship with going from caregiver back to lover. That certainly the dynamics of the relationship change. I think some of it is just lack of comfort with the provider and lack of knowledge of what's the issues are and what resources we have out there.
I would echo on that and would say I think there is general lack of training and comfort during residency, fellowship, and then finally when you become a faculty. Two, there are timing constraints and competing priorities. Three, I would say there is always a taboo or an embarrassment that can linger on, even as a provider. Then gender and cancer type disparities. And finally, I think there's just a system and resource gap. For my brain tumor patients, not only I feel compelled to ask, but I also feel obligated to ask because I have young women, young men with brain tumors, where based on their molecular and histological diagnosis, they will be going on long-term oral treatments and these, even though we don't call them chemotherapies, but they're targeted therapies. And I have to counsel them upfront that, look, this is going to be long-term and oncofertility is a real thing. And how do we best help you if you want to have more kids, but also how to best help you and your partner. So for me, it's a default because I have to discuss, but we had a very good discussion last Friday in our grand rounds where somebody just exactly what you do. She came and she made us question ourselves that why is it not integrated in all these uh, challenges which I discussed became prominent. And I would love to know from you actually, what do you suggest us to overcome that so we can take that information and share it with our colleagues?
Absolutely. I'm thrilled you asked, and I'll try to contain my answer because we're short on time and there are lots of questions. But I feel that as I've been reflecting on this, the survivorship question, it really needs to be addressed as resources for patients, survivors that are created by professionals outside of oncology and even outside of medicine whose specialization is this, so that resources can go straight to patients and survivors, maybe by ways of clinics, hospitals, especially nonprofits. But in terms of clinicians, other oncology professionals, when I've reflected, again, there needs to be a multi-entry approach. And one, in no particular order, is staff training when and where available, continuing education courses when and where available, and I'm starting to develop those. There's also resources needed, just like for patients and survivors and their partners, but similar resources needed for and written for and geared towards clinicians and staff. And so I'm starting to develop those also with others. And then the primo starting place is what I call starting with self, because before we can be effective in the clinic, before we can be effective in the therapy room or wherever the client interaction or patient interaction is happening, we need to get clear on what our own biases, our own judgments, our own conditionings are around not just sexuality and intimacy, but also body image, the biases we bring into the room around certain body types, around certain relationship styles and types, around certain sexual orientations, and start getting really clear on where are we lacking in our education, where do we have growth edges, and then what are the resources available to help us expand as professionals and have more comfort and competence. So those are all things I'm thinking about a lot.
Really appreciate that.
Mm.
And I think I have made some mental notes and
Awesome.
would certainly be on the lookout to discuss this with other colleagues.
Definitely. And I'd love to be in touch with both of you after today.
Absolutely.
And that's a good example of where a comprehensive survivorship program would start early on in that diagnosis and treatment so that they can partner with that oncologist so the oncologist can focus on the acute treatment at that time. And your survivorship clinic is helping with all these other issues.
Exactly. Yeah, thank you.
We have time for another couple of questions. I think we had a couple of hands raised that disappeared. Does anyone want to unmute or should I check the chat? Yeah, go ahead. You need to unmute though.
Hi, my name is Sue Ellen. I work at Orange Coast Medical Center at the Cancer Institute. I'm actually the survivorship alternate to our survivorship coordinator, who is also on the call. What do you recommend when you have patients who really actually kind of put the hand sign up? No, I don't need any aftercare. No, I don't want to talk to you. No, my cancer's over and I just want to move on with my life.
It's hard. You can only go where they're willing to go. And I think sometimes some of our folks need a little time to process. I think they need that couple months to get away from it, to kind of get back to their routine before they start to realize this, hey, there's a lot of here stuff I need to work on. Our survivors do a good job sometimes of packing all these issues in, getting through what they got to get through, and it works to the point that they can't put anything else in. So I think some of these folks, we just have to give them time. They're ready to address it. It's
I
hard.
really enjoyed this webinar, and I thank you all and the presenters. Thank you. Thank you. It's been illuminating.
Well, thank you for your question. I sometimes, just to add to what Dr. Bailey-Dorton was saying, would take real life examples because they will I always ask about families, and I always ask, do you have grandkids? And sometimes they'll say, oh, we can't move that well as we used to, and our grandkids are young. So I use sort of that information to help them understand that what could change if they integrate maybe a mile of walk, because I know they can walk, and maybe changing the nutrition from cookies to healthy diet, and they'll have more energy, and that seems to resonate with them the most, that using real life examples, and um, how to practically give them one or two specific plans, and then just following up on that next time.
Thank you.
Thank you. One last question. We have 2 minutes. There's one in the chat here from Lori, and she's asking, what do you think are the top 3 barriers for health systems making survivorship part of cancer care? I think that's a really good one.
I think having the personnel trained in survivorship care, because so much is focused sometimes on the acute treatment, but I think learning to make that transition to find the right people, to put the right people with the right people on the bus, that's the biggest thing sometimes. And then funding.
Wonderful. Thank you so much for being here with us today. I really enjoyed talking with our 2 speakers and hearing your experiences in running survivorship. I know that you have 2 different clinics that are set up in a very different way, so it was really nice to hear both spectrums